Także witam Państwa serdecznie na dzisiejszej sesji neurologii. Szanowną komisję, pana doktora, albo tak, jak podam mikrofon, jakby się Państwo mogli przedstawić, bo
Dzień dobry Państwu, Mikołaj Dymek z tej strony. Miło mi bardzo.
Dzień dobry Państwu. Dzień dobry, Anna Siuda, neurolog Katedry Neurologii Wydziału Nauk Medycznych w Katowicach.
Witam, Elżbieta Zych-Twardowska, również z Kliniki Neurologii.
dziękuję bardzo. I bym prosił o wyłonienie przewodniczącego komisji. Kto z Państwa chciałby być przewodniczącym komisji? Oczywiście. To mamy jeszcze panią doktor Monikę Adamczyk-Sowę, panią profesor Monikę Adamczyk-Sowę. I teraz kto z grona komisji chciałby być przewodniczącym? Tak, w czwórkę są Państwo. Dobrze, czyli czy pani profesor przyjmuje taką funkcję?
Przepraszam, pan kieruje do mnie pytanie, bo
Tak.
nie jestem pewna. Ja z przyjemnością mogę się podjąć, natomiast proszę mi powiedzieć, na czym polega ta rola.
To znaczy będzie to polegało na podsumowaniu później sesji.
Dobrze, to ja z przyjemnością mogę się podjąć. Dziękuję.
Dziękuję bardzo w takim razie. Muszę mówić przez mikrofon na takiej małej auli, ale muszę, bo jest transmisja i tylko w ten sposób słychać mnie na tej transmisji. I tak samo też w trakcie dyskusji bym prosił o zabieranie głosu również przez mikrofon, który tam zostawiłem. Członków, którzy będą prezentowali, też bym prosił, żeby używali mikrofonu i zajęli miejsce tutaj, żeby było widać na kamerze, jak prezentują. Mikrofon będzie mógł stać na statywie, będę mógł go podać też do ręki, także damy radę. Sesja będzie prowadzona w taki sposób, że prezentacje mogą być wygłaszane po polsku, natomiast tekst prezentacji musi być po angielsku. Ale rekomendujemy, żeby też treść prezentacji była wygłaszana po angielsku, bo to jest, żeby nasi widzowie też z innych krajów mogli w pełni odebrać treść przekazanych prezentacji i dyskusja również, żeby była po angielsku. Także myślę, że będziemy mogli zaczynać. Jeszcze powiem o zasadach oceniania. Na kartach do głosowania dla komisji jest rozpiska według numerów i będę za każdym razem podawał, do jakiego numeru na karcie się należy odnieść, oceniając pracę. No i to będzie 1 do 5, tak. Będą przyznawane punkty. Tak. Tak,
Jeżeli ja mogę zapytać, bo
No, tak,
nie
proszę.
jestem pewna, rozumiem, że po każdym wystąpieniu przyznawane są punkty przez członków komisji,
Tak,
czy na
przez
końcu?
członków komisji. Na kartach do oceny sesji i jest oceniana wartość merytoryczna 1 do 5, sposób prezentacji 1 do 5, dyskusja 1 do 5 i wkład własny.
A czy ja bym mogła taką kartę otrzymać, bo ja jej nie mam?
To znaczy tak, jest jeszcze strona do tego, to ja się skontaktuję, ja bym prosił o po prostu sporządzenie notatki, a potem się to przeniesie na kartę.
Dobrze,
To
to
jest,
ja bardzo proszę, ponieważ nie mam tutaj.
tak, napiszę na
Chociaż nie,
czacie,
chociaż coś tutaj widzę, że jest elektroniczna karta oceny. Jest taka.
tak, to jest to właśnie.
Aha. I rozumiem, że po każdej prezentacji mamy to wypełnić, tak?
Tak.
Mhm.
I nie są oceniane też prezentacje, jeśli członek komisji jest promotorem danej pracy, to nie ocenia jej wtedy.
Mhm.
A z katedry, tak, z katedry tak. I teraz mogę przedstawić kolejność prezentacji, która będzie. To już sobie otworzę. Kolejność jest tak jak w książce abstraktów. Tak. Za każdym razem będę podawał numer tej prezentacji. Dobrze, także prosiłbym pierwszego prelegenta. To jest prezentacja pod tytułem One Year Follow-up of Drip and Ship versus Mothership Transport Models of Mechanical Thrombectomy.
Który to jest
Tak,
numer?
tak.
Który to jest numer abstraktu?
To jest numer drugi, ponieważ pierwszej pracy nie mamy tutaj, ale to zaraz to rozwiążemy i następna będzie praca numer 1. Natomiast teraz praca numer 2.
A na której to jest, przepraszam, jeszcze przerwę, na której to jest stronie w książce abstraktów?
199.
Dziękuję.
Tak.
Ja wiem, właśnie podkreślamy numer 1.
Honorable jury, ladies and gentlemen, my name is Dominik Wrubel, and I would like to present our study regarding one-year follow-up of drip and ship versus mothership transport models of mechanical thrombectomy. As introduction, I would like to mention that as acute ischemic stroke, we define focal neurological symptoms of sudden onset that last at least kontynuować? To mogę od tego momentu, nie wiem. Od tego momentu, tak? So, drugi slajd, czy od początku? So, as acute ischemic stroke, So, as acute ischemic stroke, we define focal neurological symptoms of sudden onset that last at least 24 hours and are caused by blood supply disruption for brain tissue and subsequent ischemia. Ischemic strokes makes around 80% of all strokes, and their incidence is very high, especially in elderly population. Generally, for ischemic stroke, we've got two causative treatment modalities. They both aim to restore perfusion and thus save as much ischemic penumbra as it is possible. The ischemic penumbra is the brain tissue that underwent hypoperfusion. However, cells there are still alive and they can be saved. Intravenous thrombolysis is a non-invasive, systematically administered method that has been proven to be very effective. However, it is also very time-sensitive, as only patients presenting up to 4.5 hours from symptom onset, in some cases that could be 9 hours, are eligible for that treatment. in case of patient exceeding that time window, there is too much risk of hemorrhagic transformation of a stroke. Mechanical thrombectomy, on the other hand, is an invasive method that aims to physically remove the clot and either by aspirating or retrieving it, and thus restore the vessel patency. It has got much broader time window, as it could be applied up to 24 hours from symptom onset. For patients undergoing mechanical thrombectomy, we can distinguish two transport models. In the mothership model, patients are transported directly to the comprehensive stroke center, whereas they receive thrombolysis if it's indicated, and the mechanical thrombectomy is performed. On the other hand, in the ribbon ship model, patients are first transported to the primary stroke center where they receive thrombolysis, and then they are transferred to comprehensive stroke center where mechanical thrombectomy is applied. In this study, we aim to compare the impact of those two models on patients' vessel recanalization and long-term outcomes. Generally, there are no clear guidelines which transport model is more beneficial for those patients, and the long-term outcomes haven't been studied systematically. We included 583 acute ischemic stroke patients treated with mechanical thrombectomy in comprehensive stroke center in Krakow. We included patients between 2019 and 2021. And we also included only included patients who gave their consent for participation in the study and of whom the 1-year follow-up was available. Our main studied endpoints were effective recanalization, defined as thrombolysis in cerebral infarction score higher or even to B, and 1-year outcomes, mortality rate, and gut functional outcome rate measured by modified ranking score lesser or even 2. The sex structure and age distribution were both similar in both groups. However, the time lapse from stroke onset to groin puncture was significantly lower in mothership model, as was the NIHSS score before mechanical thrombectomy. NIHSS is a scale used globally to assess the stroke severity. On the other hand, the thrombolysis rates were significantly higher in ribbon ship model. On that bar graph on the left side of the screen, you can see that mothership model patients receive mechanical thrombectomy more often, whereas the ribbon ship patients receive both mechanical thrombectomy and intravenous thrombolysis more frequently. As for the mechanical thrombectomy complications, the rates were similar in both graphs. However, the brain hemorrhage was almost significantly higher in the ribbon ship model. Speaking of outcomes of discharge, the mothership model patients had got significantly longer hospitalization time. However, there were no differences in clinical outcomes measured by modified ranking score. In 1 year of follow-up, the ribbon ship patients had significantly lower mortality. They also had lower fetal recanalization rates and lower mean modified ranking score. However, those differences weren't statistically significant. Our study had some limitations. First, that was single-center study with very homogeneous population, and we only included patients that were eligible for mechanical thrombectomy, and also that was a retrospective analysis of partially prospective acquired data. Concluding, the ribbon ship patients received thrombolysis faster and more often, and thus they seem to have lower mortality. However, that has to be confirmed by large randomized controlled trials. Our findings confirm the fact that in acute ischemic stroke, time is of the essence, and we have to identify those patients and treat them as fast as possible. As the neurologists say, time is a brain. Those are our sources. Thank you for your attention.
Are there any questions from the audience? Maybe I'll ask first one. Okay, very nice work. Still active. Actually, your results are surprising for me because I would expect that the mother center would have better outcomes. Could you explain why it's so different?
Well, in studies, generally there weren't any differences between those two graphs. However, in our study, there were mothership-driven patients had got better outcomes. We suspect that might be because they received thrombolysis faster and more often, but that was not big population in our study, and bigger studies are needed to confirm that fact.
You said that, well, the study was quite big, I would say, for Poland.
Okay.
But to confirm those who first come to the mother center and those who were then transferred, the numbers were equal.
You mean number of patients?
Yes. Or not?
Driven-ship patients was higher. There were more patients in driven-ship patients, and they received thrombolysis more often because in driven-ship model, patients are presented to the ward faster, and they are more frequently able to receive the therapy, and it doesn't exceed that 4.5 hours time window. So we suggest that might be it, but we don't actually know.
The baseline NIH scale were similar.
I think it was lower in mothership graph. Can we
come back to this slide?
Can go back to that?
The baseline data. NIH in the baseline. I think 3 slides ahead.
Yeah. Yes, it was lower in mothership. However, 1-year outcomes were better in
so again, surprising results.
driven-ship. Yes, so it turns out that even though those graph of driven-ship patients at the baseline got higher NIHS, they've got better 1-year outcomes. However, in 1-year outcome, there might be a lot of confounding factors like deaths not caused by the stroke, but we have focused on 1-year outcomes because there weren't any publications on PubMed on 1-year outcomes, and they were about 19-day follow-up, which is like typical to assess the stroke outcomes and its treatment outcomes.
The 1-year assessment, it was made inside or by telephone?
Mostly by telephone. We called patients to evaluate the clinical status. However, for some patients, we weren't able to contact them, and we contacted their closest family to ask how the patient is doing.
So what was your personal input to the study?
We've gathered data from our hospital database. Part of that data we gathered prospectively by calling those patients to evaluate their clinical status. We also developed an idea. We calculated statistics, created presentation.
Any other questions from the jury? Okay, thank you for your presentation. Prezentacja numer 1, która miała tutaj zaczynać naszą sesję neurologii, będzie jeszcze przesunięta o 1 w dół, bo mamy problem z pobraniem jej z systemu. Teraz będzie prezentacja numer 3, oceniana w kartach na pozycji numer 3. I jest to prezentacja pod tytułem The Efficacy of Deep Brain Stimulation of the Subthalmatic Nucleus in the Treatment of Parkinson Disease. Barbara Buchalska, Karolina Jaros, Agata Marszałek.
Dzień dobry. To ja mam udostępnić swój ekran, tak?
Tak, proszę udostępnić.
Dobrze.
Tak, muszę ekrany przełączyć.
To przepraszam, bo ja jeszcze muszę na chwilę wyjść ze spotkania, bo mi się nie chce udostępnić ekran. To...
Tak, widzimy już panią.
Dobrze, to jeszcze... Czy jest widoczny teraz ekran?
Jest widoczny, tak.
O, dobrze. To... Good morning, my name is Barbara Buchalska, and today I'll be presenting a presentation about the efficacy of the deep brain stimulation on the subthalamic nucleus in the patients of Parkinson's disease. The Parkinson's disease is the most definitely one of the most commonly diagnosed movement disorder nowadays. It's associated with many disturbing symptoms, mainly rigidity, bradykinesia, and rest tremor. We can also observe stop posture, reduced arm swing, flexed elbows and wrists, and masked facial expressions. Other symptoms may include speed changes, loss of smell, impaired balance, and also autonomic symptoms such as flatulence. Also, patients with Parkinson's disease observe non-motor symptoms, which may include depression, anxiety, apathy, psychosis, dementia, cognitive impairment, disorders of sleep and wakefulness, also pain and fatigue. And they significantly alter the quality of life of such patients, along with the motor symptoms. And the main treatment of Parkinson's disease nowadays is pharmacotherapy, mainly with levodopa, but also other drugs. But for patients with advanced Parkinson's disease, the options are limited. And the deep brain stimulation is a good treatment for patients with such advanced Parkinson's disease in which the drugs are not so effective. It has a high effectiveness in controlling motor and motor symptoms and improve the quality of life. And one possible localization for deep brain stimulation implantation is the subthalamic nucleus, or STN. And this localization is the most commonly used in the treatment of patients with Parkinson's disease. And here is shown how this device looks like. So on the chest is the pulse generator, which creates the pulses, which then go to the lead, and here it is inserted to the subthalamic nucleus. The aim of the study was the assessment of the efficacy of DBS-STN in the treatment of non-motor and motor symptoms in patients with Parkinson's disease. We recruited 29 patients, 8 women and 21 men, with a mean age of 58 years, who had idiopathic PD and underwent DBS implantation procedure. And the assessment with using the questionnaires and scales was done twice, before the DBS implantation surgery and approximately 24 months after the implantation. And for the assessment of the Parkinson's disease, we used several scales and questionnaires. For the assessment of quality of life and motor symptoms, we used PDQ-8 and PDQ-9, which assess the aspects of everyday life of the patients. For example, how they can function at home or how far they can walk. And the non-motor symptoms of PD was assessed using the PDSS scale, which is used to assess the quality of sleep. The Epworth Sleepiness Scale, which assess how the patient is likely to sleep in everyday situations, like while driving a car or at home after the dinner. We used also TAS-20 scale, which assesses the alexithymia, which is the term used for patients who have troubles identifying and describing emotions. We used HADS scale, which assesses anxiety and depression, AES scale, which assesses apathy, and SRMI scale, which has questions assessing if a patient has episodes of mania. And the results. We found only 3 scales to be statistically significant. The first of them is PDQ-39 score. Before DBS, it was approximately 56 points, and after it was 33 points. It decreased by 44%, indicating a better quality of life. The other statistically significant scale was PDQ-8 scale. Before DBS, it was approximately 12 points. After 8 points, it decreased by 33%, also indicating a good quality of life. And the last statistically significant scale was PDSS, assessing the sleep. And before it was approximately 90 points, after approximately 110 points, it increased. But this is good because the higher the score in this scale, the patient is more likely to have a good quality of sleep. And the other scales assessing the non-motor symptoms like AES scale, the SRMI scale, and others were not statistically significant. And the conclusions, our studies showed that DBS STN implantation may significantly improve the quality of life of patients with Parkinson's disease, which was shown mainly in the PDQ-8, PDQ-39, and PDSS scale. It may have a beneficial effect on non-motor functions, but it does not significantly alter mania, apathy, emotional problems, because the results in these scales were not statistically significant. And thank you for your attention.
Thank you for your presentation. Any questions from jury?
Yes, I would like to ask you, firstly, I would like to congratulate very interesting work. And I would like to ask about your personal own role in this study, I mean in practical aspects.
So me and my colleagues, also students, were conducting the questionnaires and scales. We were going to the clinic and the neurology ward, and we were taking the scales and questionnaires from the patients.
Before I would like to ask you, I'm sorry, before the treatment or after?
Before and after the treatment.
Okay, thank you very much.
I have one methodological question. Those patients were operated on both sides at one time, or this was like 2 operations divided with time?
It was, some patients were operated 2 sides at once, and some had 2 operations.
So you didn't differentiate in your group?
No, we didn't.
Okay. Another question, because you said like final data, and you said that the observation was prospective and it was up to 48 months, as I remember.
Yes.
We know that the patient's outcome changes within time. There were any differences, let's say, after 12 months compared to 48 months?
We didn't assess it yet, so I don't know.
And do you know the data, those that actually were not significant before the operation? How many patients were positive for apathy, mania, or other psychological problems? Because they may not be statistically significant because they were very low at the beginning.
No, like, I don't know, maybe 20% of patients were positive for mania, apathy. It was high in both groups, before and after.
Okay, thank you. Any other questions here from the audience? So thank you very much.
Thank you.
Thank you for your presentation. To była prezentacja kolejności trzecia. Teraz będzie prezentacja oceniana na karcie na pozycji numer 4. Będzie to prezentacja pod tytułem Comparative Analysis of Giant and Nearly Giant Pituitary Adenomas, prezentowana przez Barbarę Buchalską. Prezentacja, która miała być na samym początku, jest przesunięta jeszcze o jedną pozycję w dół, bo cały czas walczymy z systemem, ale zaraz to będzie zrobione. Także prosimy panią Barbarę Buchalską.
To ja mam udostępnić ekran też?
Aha, nie, przepraszam, to już była, ta prezentacja już była, tak.
Znaczy
była...
nie, bo to jest druga, ja miałem
Dobrze,
drugą.
to tak, proszę udostępnić
Dobrze.
ekran, tak.
To przepraszam, bo ja nie mogę udostępnić, jeżeli pan udostępnia teraz.
Tak, ja muszę zatrzymać. O, teraz może pani.
Dobrze. O, czy teraz jest widoczna prezentacja?
Teraz jest widoczna ta prezentacja, która była poprzednio.
A teraz?
Też wciąż widzimy tą poprzednią prezentację.
A teraz comparative analysis?
Tak, widać, jest idealnie.
So good morning, my name is Barbara Buchalska and today I will be presenting a study titled Comparative Analysis of Giant and Nearly Giant Pituitary Adenomas. Here are shown the sizes of pituitary adenomas, because we can divide pituitary adenomas as microadenomas, which are under 1 centimeter of diameter, macroadenomas, which are above 1 centimeter of diameter, and the giant adenomas, which are above 4 centimeters of diameter. And the giant pituitary adenomas comprise 6 to 10% of all pituitary tumors. They have the greatest dimension of 4 centimeters. They are more common in men, and they are mostly hormonally inactive. And the main symptoms which patients present are vision problems and headaches. And here we can see some MRIs of patients with giant pituitary adenomas. And we also included a group of nearly giant pituitary adenomas in this study, which are defined as having a greatest dimension of 4.5 centimeters and under 4 centimeters. They are similar to giant pituitary adenomas, but they are a little bit smaller. They are also mainly hormonally inactive, and they cause similar symptoms like visual problems. And here is the comparison of nearly giant and giant pituitary adenoma. So they are nearly the same. And the endoscopic transsphenoidal surgical treatment in the last 2 decades is becoming increasingly more popular as a method of choice in the treatment of giant and nearly giant pituitary adenomas and all pituitary adenomas. It's efficient and minimally invasive method of pituitary tumors removal and is considered safe and allows for a greater tumor resection than craniotomy. This is shown how the endoscopic technique looks like, which we used in our patients. And here is the panoramic view made in the operation of pituitary adenoma. And the aim of this study was the evaluation of the results and safety of endoscopic transsphenoidal surgical treatment of the giant and nearly giant pituitary adenomas at the Department of Neurosurgery in the National Research Institute of Oncology in Warsaw. This was a retrospective analysis of patients with giant and nearly giant pituitary adenomas. And the first study group comprised 170 patients with giant pituitary adenomas or GPAs, and it included 65 women and 105 men. And the second study group comprised 32 patients with nearly GPAs, and 6 women and 26 men. And the characteristic of test group was mean age in both groups was similar. The observation time was slightly shorter in nearly GPA's group. The vision problems were also observed less commonly in nearly GPA's group, but pituitary apoplexy was observed more commonly in the nearly GPA's group. And the results. There were similar percentages of patients having functioning tumors and non-functioning tumors in both groups. But the invasive tumors were significantly more commonly observed in giant pituitary adenomas group. And the invasive and also proliferative, so high Ki-67 index, were also more commonly observed in the GPA's group. And the KNOSP scale, which is used to assess the pituitary adenomas and shows the proximity of the tumor to a cavernous sinus and other vital structures. So grade 2 was more commonly observed in giant pituitary adenomas group, but grade 4 was also more commonly observed in giant pituitary adenomas group, and it indicates the invasion of the cavernous sinus and the enclosement of the internal carotid artery. And considering the histopathological diagnosis, giant gonadotroph pituitary adenomas were more commonly diagnosed in nearly GPA's group. And sparsely granulated somatotroph adenoma and null cell adenoma were not observed in the nearly GPA's group, but were observed in the GPA's group. And the complications. So more patients were showing complications in the GPA's group than in nearly GPA's group. The transient diabetes insipidus was twice as common in GPA's group as in nearly GPA's group. And in nearly GPA's group, we did not observe other symptoms than diabetes insipidus, but in the GPA's group, we observed also hematoma, worsening of vision, hydrocephalus, cerebrospinal fluid leak, meningitis, epistaxis, stroke, and we had also 2 cases of death after the operation. Here is shown how we evaluated the Ki-67 index. And so under 3%, the cells are nearly not stained, and where it is above 10%, we can see the stained cells. And here are some cases of our patients. And here is a case of 62-year-old female with vision problems. And here's the preoperative MR. We can see a giant pituitary adenoma, and here the postoperative MR. You can see a good extent of resection. And here another patient, a 40-year-old male with vision problems. This is the preoperative MR, also giant tumor. And here the postoperative MR, we can see a good extent of resection. And the conclusions, our study showed that giant pituitary adenomas differ significantly from nearly giant pituitary adenomas in both clinical and morphological aspects. And the diagnosis of pituitary adenoma with a maximum diameter above 40 millimeters is associated with a poorer prognosis and should prompt a more intense treatment. And thank you for your attention.
Well, thank you very much for your presentation. It was a very well presentation. I have actually a few questions speaking from the neurosurgical side, neurosurgical point of view. So my first question was how long was the follow-up? Could you please remind me how long was the follow-up of the patient?
Follow-up was approximately 7 years in giant pituitary adenomas and 6 years in nearly giant.
Okay. So my first question is did you differentiate, if any, if some patients underwent a further treatment after the surgery? Because I suppose that not all of the surgeries were like gross total resection of the tumor. Probably it was a partial resection of the tumor. So do you have any information about that?
Yes. the treatment after the initial surgery was usually not initiated because the patients did not have significant symptoms even after partial resections. Several patients from the giant pituitary adenomas group had other operation because of the recurrence of the disease, but not the newly giant pituitary tumors.
Okay, thank you. And my last question is about the quite maybe not common, but in big pituitary adenomas, complication of surgery, which is a CSF rhinorrhea. Did you find that patients who were operated in your center, was it every time the same type of operation? Was the so-called plastic surgery of the dura mater, was it the same way, the prevention of the CSF rhinorrhea, or not? Maybe this question is a little bit too specialized, but if you have any information about that.
Yes, it was. The doctors have done the plastic, like they included the operation techniques to close any like tears in the arachnoid, and they included the mucosal flaps and
okay.
the adipose tissue grafts.
Okay, so and every time in every surgery, if this plastic surgery was required, it was the same method used, yes?
Yes, it was the same.
Okay, thank you very much.
I have one question, if I may. Those two fatal cases, those that finish with death, have you have data? What was the cause of death?
Yes, in one case it was the sepsis and the DIC, and the other was the hydrocephalus and coma.
One more question. What is your personal input to this study?
I created this database. I found patients, and I also called them to do the follow-up after the surgery.
Okay, thank you.
Thank you for your presentation.
Thank you.
Teraz dziękujemy i zapraszamy prelegentów, których chcieliśmy wypowiedzieć na samym początku. To będzie praca, która będzie oceniana pod numerem 1. I zapraszamy. Praca pod tytułem Morphologic Analysis of Normal Human Lumbar Ganglia Spinalia, a Story About Big Ganglia and Where to Find Them.
Ladies and gentlemen, today I would like to bring up those topics and Today I would like to bring up those topics, and to start I would like to say something about ganglion. So what is it in a definition? It's a collection of neuronal cell bodies in the PNS. And I would like to emphasize that dorsal root ganglion in some articles is called ganglia spinalia in other. So both terms are correct and commonly used. Where to find ganglia? This is a very important question because we've got actually three locations. The first one would be dorsal roots of spinal nerves. The second, cranial nerves. And the last one would be autonomic nervous system. So ganglia spinalia actually contain the cell bodies of all primary sensory neurons, and they look like this. Here we can see an individual human spinal segment in two different aspects. So the first one would be in a ventral aspect, the second one is the lateral one. We can see also a formation of a spinal nerve by the union of dorsal and ventral roots. Please note that the ganglia spinalia actually are located extremely near to the place where ventral and dorsal roots join all together, making the spinal nerve. Here we can see a part of human spinal cord, because I wanted to show you three layers of meninges that protect the spinal cord. And those photos come from our work. So we can see spinal cord before opening spinal dura mater and after in the third photo. Don't worry, I'm not going to speak so much about it. I just wanted to emphasize that there is a lot of uses for knowledge of architecture, morphology, location of ganglia spinalia in different disciplines of medicine, for instance, anatomy, anesthesiology, and obviously neurosurgery. Our purpose was to clarify the normal morphologic features, location, and variations of lumbar ganglia spinalia. We focused mostly on L3, L4, and L5 levels. So microanatomic dissections have been made using Zeiss surgical microscope with 5 fixed human cadavers. And having done also PubMed research and some other databases, we found only 3 articles covering ganglia spinalia topic in different ways. It was mostly actually morphology, architecture, and location. So ganglia spinalia can be divided into 2 groups. So the first group would be with bifurcation of both ventral and obviously dorsal roots ganglion. And in the second group, there would be no bifurcations at all. The first group can be then divided into 3 types, depending on how many ganglia spinalia we've got and how many ventral roots there are present. In here, on the left side, we can see some results from an article that we found. And on the right side, actually even there, we can see a big ganglia that we have found. So it's like 2 different seemingly independent ganglial components. And another example in here. Here we can see ventral roots from our work. And big ganglia once again, some nice examples. I would like to emphasize that actually there can be monoganglia, big ganglia, and triganglia. So depending on how many seemingly independent ganglial components we've got. And what's extremely important, big ganglia can be found mostly at the level of L3 and L4 in almost half of the cases. In here, we can see some big ganglia in here, monoganglia, triganglia, in the quite different way of MR imaging. And we can also divide ganglia spinalia into 3 types depending on location. So we've got intraspinal, intraforaminal, and obviously extra foraminal type. I would like to emphasize that obviously proximal and intraforaminal position, location of ganglia spinalia makes it much more sensitive to be, for example, compressed by different structures. For example, foraminal disc herniation or stenosis. So it would be extremely important if there is a chronic pain, for instance. What we have found is that at the level of L4, all roots were bifurcated, at the level of L5 as well. At the level of S1, there was no bifurcation found at all. So to conclude everything all together, I would like to emphasize the importance of existence, the knowledge of monoganglia, triganglia, and big ganglia, obviously, because the better knowledge we have as neurosurgeons, for instance, about this morphology and architecture, the better results in different therapies that already exist we've got, because, for example, the electrode to stimulate those ganglia spinalia is obviously better, so the results of treatment will be also better. Thank you very much.
So thank you very much for your presentation. Very interesting work. And my first question was, could you please remind us about your contribution? What did you did during working?
My part was to do the preparation of fixed cadavers and obviously article research, but I have to set about PubMed research, but also obviously we were searching different databases, for example, Google Scholar and so on.
And my second question is, did you find any interesting or important practical implementation of the things that you found? Is there any significance, for example, for the treatment that I think now is, for example, using a thermal lesion, for example? This is a method that we use to destroy nerve components to denervate the structures of the spine, for example. Did you find any kind of works that describe that there is implementation of the thing what you said, that there is a difference, for example, or some kind of maybe dangers, or the danger of the operation being not successful because of this kind of anatomical differentiation between the patients, for example?
Basically, we have found no articles covering these topics that you were saying, but actually, according to this topic, I would like to say that actually morphologic analysis is very important because, as you said, for example, if we have to do any if we want to use any treatment, we have to have the right location, the proper location to use, for example, our tools that we're using in these different therapies. For instance, if we have a patient with, I don't know, chronic pain or sciatica, whatever, then we have to, for instance, use different electrodes to stimulate ganglia spinalia, and to know the correct location where it is. This work is extremely important.
Yes, you're very right. Thank you very much for your answering.
Any questions? The audience is so silent as for now, at least.
Thank you for your presentation. Prezentacja, która będzie oceniana teraz, to będzie prezentacja pod pozycją 5. Jest to prezentacja pod tytułem Endoscopic Third Ventriculostomy in Pediatric Patients. Wiktoria Pniok, Zuzanna Olejarz i Magdalena Iwan.
So good morning to dear distinguished jury and esteemed audience. It is my great pleasure to be presenting for you today. My name is Victoria Pniak, and I would like to demonstrate our work titled Endoscopic Third Ventriculostomy in Pediatric Patients. To start with, the ETV is a minimally invasive method of treatment of obstructive hydrocephalus. It involves creating a small incision in the floor of the third ventricle in order to create an alternative pathway for a cerebrospinal fluid to flow out of the ventricle. Due to the fact that ETV doesn't require making any big incisions, it may also be called a keyhole surgery. ETV is indicated in obstructive hydrocephalus due to tectal tumors, aqueductal stenosis, that example of which we can see on the MRI on the right, and intracranial cysts, Dandy-Walker malformation, posterior third ventricle tumor, and intraventricular hematoma, but in some cases as well for the normal pressure hydrocephalus and shunt dysfunction. The aim of our study was to assess indications for surgery, treatment, clinical picture and treatment outcomes in all of the patients with HCP treated with ETV. And our study is a retrospective analysis of all the patients that underwent ETV procedure in the Department of Pediatric Neurosurgery of Katowice between 2013 and 2023. And after conducting a thorough analysis in a cohort of 492 patients, we selected 63 individuals with an almost equal gender ratio of 31 females and 32 males. The mean age for all the patients was 6.32 years, and the age range was between 1.5 months to 17 years old. The most occurring symptoms in all of the patients were head pain, increased head circumference, neurological deficits, and nausea and vomiting. Less than 20% of the patients also presented with alteration of consciousness and neurodevelopmental disorders. And in some cases, we've also reported such symptoms as papilloedema, strabismus, tense fontanelle, speech disorders, nystagmus, and Porinel syndrome and depression. And as you can see on the second slide, the ones that are marked pink are symptoms specific for intracranial hypertension, which resulted in a conclusion that symptoms of increased intracranial pressure were the most common manifestation, occurring in 82.5% of the patients. Etiology of hydrocephalus was different. First, we had tumors, a diagnosis of tumors, then followed by aqueductal stenosis and intracranial cysts. And the fourth category, others, refers to stenosis of the foramen magnum, narrowing of the foramina of Monro, and shunt dysfunction. So where were these obstructions actually located? When it comes to cysts, more than 40% of all of the cysts were located in the quadrigeminal cistern, and less than 30% were located in the posterior fossa, and the same amount in the cerebral aqueduct. While when it comes to tumors, the majority of them were located in the tectal plate. 1/4 of all of the tumors were located in the pineal gland, and we've also reported one case of isolated third ventricle tumor. In majority of cases, ETV was the only performed procedure, while in 11 cases it was also extended with a tumor biopsy, and in 3 another patients with endoscopic ventricular cystostomy. Obstructive HCP due to tumor was diagnosed in the group of 28 patients. 11 of them received ETV alongside with biopsy, where 2 of those 11 patients did not receive any histopathological diagnosis, resulting in 1 of them having to undergo a second surgery. In the group of 17 patients that had an isolated ETV, 5 of them required total tumor resection, while in the rest of them, 12 of them, tumor resection was not required at all. And all of these 12 patients were diagnosed with a benign tectal mass that we see where the red arrow is pointing. Here we see a before and after the ETV procedure. And before we can see the benign tectal mass of both of them, but aftermath of the procedure is the creation of the small incision in the floor of the third ventricle. In the short-term observation, symptoms of intracranial hypertension resolved in almost all patients. During the follow-up period, with a mean of 4 years, 3 children required repeated ETV, while in 12 cases, shunt implantation was necessary. Overall success rate of the procedure was 76.2%. Post-operative complications were reported in 10 patients. And 4 of these complications were actually severe. In 3 cases, we've had leukorrhea that required a 1 resuturing, and one case of diabetes insipidus with panhypopituitarism. The other ones were milder, and there were 2 cases of leukorrhea that didn't require any surgical treatment, and 1 of each of transient left-sided paralysis, transient diplopia, muscular hypotonia, and mild upper respiratory infection. So, 3 major conclusions came out of our work. The first one, that ETV is an effective and safe method of treatment of obstructive HCP in children. The second one, that in the case of HCP being caused by a neoplastic process, the ETV itself may be also extended with a tumor biopsy. And the third one, that in the case of radiologically proven benign tectomas, ETV and a follow-up MRI were sufficient without any need of biopsy or further tumor resection. So thank you very much for your attention, and feel free to ask me any questions related to our work.
Thank you for your presentation. I would like to ask you about the group of patients. Did you exclude some malignant tumors, I mean in pathomorphological tests?
And no, we have malignant tumors as well. Mainly occurring histopathologic diagnoses were germinomas, pilocytic astrocytomas, pineoblastomas, and PTPR, papillary tumor of the pineal region.
Mm-hmm. And I wanted to ask about the treatment of these malignant tumors. I mean, apart from the treatment about you told us before, but I would like to ask about some additional treatment.
Well, we've reported
about, chemotherapy or some surgical additional therapy.
We reported only the surgical aspect of the treatment of these tumors, and just the tumor resections. We didn't really collect the database about the chemotherapy.
Mm-hmm. In my opinion, it's a very important issue because your results are could be strictly related with some other follow-up treatment and observation in these malignant cases. Thank you.
Thank you.
So my question, first of all, thank you very much for the presentation and congratulations on that. My question is about obviously complications of that surgery. Did you find that these complications are more common, or maybe mostly common, in the situation where the ETV is performed with the tumor biopsy, or that the ETV complications are much more common when there is any kind of tumor present in the third ventricle or around?
And no, we haven't found any relativity of these 2 factors.
And how about this, the case of panhypopituitarism that you find? Was it, do you know the case exactly? Was it about the patient with the tumor, or was it just a complication of a simple ETV?
It was a patient with the tumor, yes.
Yes, this is why I ask you this question, because this endoscopic surgery can sometimes be not only performing an ETV, but also being a complete resection of the tumor of the third ventricle. It is sometimes possible, and this complication is maybe not very common, but very dangerous complication, and it happens can happen commonly in the tumors which affect the floor of the third ventricle. So that's why I ask you this question about this patient actually, and if you found that some complications are much more common if there is a biopsy performed. But you say that you didn't find any relation.
We didn't really find the relativity. Where five of the cases were leukorrhea, and it was just the mother of the wand itself. So the other ones that appeared in one case, we couldn't really find the relativity to that.
Thank you very much.
And I have one more question, following one of the previous questions. You showed in the cases with tumors, then some of the patients were treated with the procedure and the biopsy.
Yes.
And what was the basis of the decision that the procedure was with or without the biopsy?
Mostly the radiological, the MRI, preoperative MRI. Any questions from the audience?
Hello, good morning. Just a good question about the technical part of the endoscopy. My first question is about the entry point of the endoscopy. Do you plan it with some anatomical landmarks, or do you use navigation for the system for the surgery? It's the first question. And second question about the team for endoscopy team. How many people is involved? Because it's 400 endoscopy procedures, which is quite a big number of the endoscopy procedures. And the question is how many people is involved? So how many surgeons perform this endoscopic procedure? Is one person or more people?
Coming back to the first question you've asked about the
entry point, yeah. Mainly, how do you plan the entry point of endoscopic procedure?
Well, as far as I'm concerned, they are planning with a neuronavigation, but I've never seen it in my own eyes. It's hard to say. And the second question is how many surgeons are...
Yeah, because usually there is some learning curve, and especially when you have some problems, especially pituitary problems, it means there are some problems, complications. It's usually connected with some learning curve. And if you avoid those complications, mostly it's based on your experience. And if you have a team which consists of many surgeons, of course, there's no big experience. If it's one or two surgeons for 400 procedures with school, but you have to be, of course, very well trained for this procedure.
Well, the number of the surgeons for this particular procedure is mainly two.
Two people.
Yeah.
Okay. Oh, thank you. Thank you very much.
Thank you very much.
Thank you for your presentation and discussion. Następna prezentacja, do której przejdziemy, to będzie następna prezentacja będzie oceniana pod numerem 6 na kartach do oceny i jest to prezentacja pod tytułem The Importance of Urinary Symptoms to the Quality of Life or RRMS Patients.
Thank you. Okay, so good morning, dear committee, dear participants. My name is Martin Dudek, and I'm here to present to you the study on the importance of urinary symptoms to the quality of life of relapsing remitting multiple sclerosis patients. I was prepared together with my colleagues Tomasz Fura and Julia Sildorf. So, thank you. Urinary disorders are one of the many symptoms in multiple sclerosis, and probability of occurrence of these symptoms grows with the duration of the disease. And most common reported symptoms are urinary frequency, urgency, nocturia, and urge incontinence. And bladder disorders are often unpleasant and problematic for the patients, therefore may be affecting the quality of life. And by that, the goal of work was simple, just to assess the influence of the symptoms, of the urinary symptoms to the patient's quality of life. So in our study took part 49 adult volunteers diagnosed with relapsing remitting multiple sclerosis that were treated in the department and the clinic of neurology of Medical University of Silesia in Katowice. In the study took part patients both with urinary tract symptoms and without them. And out of those patients, 30 of them were male and 19 were female, with mean age of 30.7 and mean duration of the disease of 9.3, and the rest of basic characteristics of our patients are shown in the table. Patients were asked to fill a 8-item actionable bladder symptom screening tool, King Health Questionnaire, the Multiple Sclerosis Quality of Life Inventory, and a shared survey which checked basic information about patients, the history of multiple sclerosis and bladder dysfunctions. We've also examined patients' physical functioning using 2 tests, 9-pin test and 25-step test. And out of 54 stationary surveys distributed, 49 of them were completed and turned back. So the ABSST is an 8-question questionnaire that assess patients' urinary disorders, measuring their severity in a 4-point scale. And maximum score of the ABSST is 8, and a point is given for the presence of moderate or severe symptom. And we've used the ABSST to define the level of advancement of the dysrhythmic disorders in the symptomatic group. The King's Health Questionnaire consists of 21 questions assessing the impact of dysrhythmic disorders on the 10 domains of patients' quality of life, and the higher the score, the worse. And the MSQLI is a tool that consists of 10 individual scales. Each of the individual scales generates a single separate score. And as the MSQLI evaluates lots of SM-related symptoms, we've only used those scales that were relevant to the aim of our study. And we've divided our patients into 2 groups, the symptomatic and asymptomatic, based on the answer to the direct question about having problems with bladder disorders. And let's move on to the results. Out of those 39 patients, 19 of them reported that they suffer from urinary disorders. And as you can see on the table, there is statistical significance in both H and EDSS score between those 2 groups, with respectively of 35.36 years in the symptomatic group versus 37.7 in the asymptomatic group, and with the EDSS of 3.71 versus 2.29. No statistical significance were found in calculating the physical functioning tests, yet as you can see in the symptomatic group, the results are slightly worse, with about 2 seconds longer mean times of the trials. And when we are doing the statistical analysis, the alpha level of those calculations was really close to the 0.05 threshold. So we believe that further examination could reveal some of the differences. And the mean ABSST score of the symptomatic patients was 2.2 with a standard deviation of 1.7. And as I said before, the maximum is 8. Let's move on to the King's Health Questionnaire results. As you can see on the presented graph, the presence of urinary symptoms affect almost every aspect of patients' quality of life. For example, like general health perceptions, physical limitations, social limitations, sleep and energy, and so on. We found no correlations only in the personal relationship scale. But what it tells us, what is most important from that, is the presence of these symptoms affect things such as doing chores, jobs, activities are outside the house, social life, and others, which are the basics of everyday functioning. And this leads us to the results of the MSQLI. And as I said before, we've only used some of the subscales and scales of this questionnaire, which are shown in the table. And we've found that in the symptomatic group, there are worse results of the SF-36 physical component scale, bladder control scale, which is obvious, mental health inventory, MHI, and a modified social support survey. We found no correlation in the SF-36 mental component scale in the bowel control scale, but similar to the physical functioning test, the statistical analysis was very, very close to the 0.05 level. So we believe that further examination could reveal those symptoms. And both PCS and MCS are part of the SF-46 questionnaire, which assess the quality of life, and they are calculated based on 8 subscales, such as general health perceptions, vitality scale, physical and social functioning, and many others. And out of those 8 subscales, in 5 of them, we found significant differences with worse results of quality of life in the symptomatic group, which correlate of the results of the King's Health Questionnaire. So, summing up, the presence of urinary symptoms is linked with both with age, higher EDSS, and worse mental health. And what is most important is that it impacts patients' everyday functioning, worsening already reduced quality of life by other harsh and limiting symptoms of multiple sclerosis. And that's all I wanted to present to you. Thank you for your attention. And now I want to invite my colleagues to the stage to help me with some questions. If you have some, feel free to ask.
Maybe I will be the first. Thank you for your presentation. I would like to ask you about some methodological issues. The first is my question about your role in this study.
So we've personally went to the clinic and talked to the patients, gathered their consent, talked to them about their symptoms, about their problems. We've helped some of them to fill the questionnaires, as some of them weren't able to fill them by themselves, and we've did our statistical analysis by ourselves and gathered all the data, created that database and the results by ourselves.
Did you ask patients about urinary problems?
Yes. And some of the patients, that's quite interesting that some of the patients, I remember that one patient, a very young patient that had about 25 years old, and his first relapse was the urinary symptoms, and he was very surprised and very glad that we talk about this topic, and he was very keen to work with us and to fill those questionnaires. And that like empowered us to continue the work. Like that, what he said, that it is very important for him.
I would like to ask you about your meeting with the patient, because our patient with MS very in our communication, our patients very rare want to talk about urinary problems. Did you, or maybe in some other way, you divided the problems, all your groups into two main groups: urinary symptoms present and the second one without. What do you mean about urinary symptoms of these problems?
So,
what kind of question did you perform? Because it is very difficult for us clinicians, MSologists also, talk with our patient, and we don't have adequate tool to evaluate this kind of problems in our MS group patients. So I would like to ask you about exact questions, exact tool to evaluate the urinary problems, and because it's the main thing which allow us to complete this group, this patient group.
Thank you for that question. That is very important, because we've discussed a lot when we were planning our study how to divide those patients, as we had some concerns that some of the patients may not be keen to answer and to say to the students that they suffer from those symptoms, since they may be ashamed of those symptoms, and some of the patients.
I don't like. No. I want to ask you about not shame, but about exact methodological tool to evaluate these problems, which allow us to divide and create these two kind of groups, the main aim of your study.
Yes. I think that out of those questionnaires that we've used, the best would be the 8-item ABSST, because it's short and it gives points for the presence of moderate or severe symptom that allows us to divide those patients better. And when we were asking our patients about the presence of these symptoms, we've asked them directly, do you have bladder problems? And we've told them, do you have urinary frequency, do you have urgency or urge incontinence? And some of the patients that suffered from them, that had problems with them, reported them immediately that yes, they do have those problems, and they were included into the symptomatic group. And some of the patients that stated that they do not have those problems at first, but when they were filling those questionnaires, it turned out that they already have some level of those symptoms, that they are not maybe self-aware yet. They may be not a big problem for them for now, as they probably suffered from worse symptoms in the previous relapses. And that's why we've tried to divide those patients into those two groups based on that answer, as we thought that if patient is directly saying yes, that he has those symptoms, we thought that he already have a big problem and he needs help with it.
I ask you about this issue because for us, MS experts, very difficult to evaluate this kind of problems of symptoms in our patients, and we don't have to date any adequate tool to evaluate is. So
I think,
in my opinion, we need more objective tools, tests to allow us to create these methodological groups. I appreciate your work, of course, but based to the methodological aspects, I have many issues about this kind of division of your patients.
I think that patients are asked about those symptoms in the EDSS scale. So I think that is important when the patients are evaluated in the EDSS scale to not ask them quickly, but to ask them symptom by symptom, ask them about the level of the advancement of these symptoms, and maybe take some time off on this matter when evaluating the EDSS.
Regarding EDSS, I'm not sure if you know it. One of functional scale FS is urinary problems, and
yes, that's
my main talk about this is related with EDSS scale. It's my issue, and I think that maybe in the future we will have some helpful tests and some objective tools for evaluate this very important problem in our MS patients. Thank you very much.
Thank you.
Thank you for your presentation. Następna prezentacja będzie oceniana na karcie pod numerem 7 i jest to prezentacja pod tytułem Surgical Treatment of Lumbar Disc Herniation in Pediatric Patients.
Dear jury, ladies and gentlemen, I am honored to present my research about the surgical treatment of lumbar disc herniation in pediatric patients. So, it is a very rare condition among children, and they constitute only about 5% of all patients treated for discopathy. It is extremely rare below 12 years old. Okay. And it has short follow-up time. So the possible risk factors are injuries, obesity, congenital spine defect, genetic factors like cystic fibrosis, and advanced sports. And few more words about the discopathy in pediatric population. The most common levels are L4, L5, and L5S1. They have worse effects of conservative treatment than in an adult population. And because the disc is very elastic, it is not prone to spontaneous resorption. And when to operate, you may ask? Well, there currently are no clear guidelines, but they are usually stated as the presence of a herniated disc confirmed by the MRI study with some neurological deficits and back pain, which, it is important, is unresponsive to conservative treatment. So we aimed to analyze indications for surgical treatment of lumbar disc herniation in children and evaluate post-operative outcomes in our department in Katowice. So we conducted a retrospective analysis of medical documentation of children surgically treated for disc herniation in our department in Katowice from 2011 to 2022. And we analyzed radiological results, clinical manifestation, the treatment method, results, and follow-up. So now moving on to the results section. Our study included 22 patients, and the mean age during operation was 15.5 years. And risk factors that we noticed were advanced sports in 4 cases, obesity, injuries, and as you can see, the year 2020, there is a big decrease in operations when was the COVID pandemic's breakout. And then you can see in year 2022, the big increase of operations rate. And we can suggest that the risk factors were connected to the COVID pandemics because the lifestyle of children, the lockdown thing, may have changed their habits, led to performing less sports, less physical activities. So the most common clinical manifestation was sciatica in 100 cases. No patients presented sphincter dysfunction, and conservative treatment was implemented in all of the patients in our group. So MRI was done in all patients, and the most common herniation levels were L4, L5, and L5S1. The microdiscectomy was performed to all patients. Fenestration was preferable approach technique, which was used in 91% of all cases. In 3 cases, bilateral decompression of the spinal canal was performed. And in 3 cases, the discectomy was completed with the implantation of a prosthetic reinforcing the annulus, twice in 2015 and once in 2018. So here you can see the 3 pictures of the course of procedure and the early outcomes. You can see the decrease of mean stay from 2021 and before 2020, it was 9.2 days, and after 2021, it was 5.8 days. So the early outcomes. On the day of discharge, all patients reported improvement, even slight, but in one case, the transient sensory disturbance occurred, which then subsided. And in 3 cases, transient severe pain in the operated area was present, but the patients were treated with painkillers, so it also subsided. So the mean follow-up time was 37 months, and during the observed period, reoperation was needed only in 3 cases. In 1 case, after 12 days after the first operation, in 2 cases, after almost half a year after first operation. So late follow-up, all patients reported improvement in baseline pain. All patients with preoperative neurological deficits with like hemiparesis, sensory disturbances, also reported resolution of deficits. And no patients report ongoing spinal pain, which may limit their usual normal everyday activities. Now the conclusions. So microdiscectomy represents a safe and effective treatment method for operating children with lumbar discopathy. And of course, when conservative treatment, which should be always implemented, fails, possible risk factors for lumbosacral discopathy in our group include obesity, prolonged sitting with limited physical activity, and this might be caused by the mentioned earlier COVID pandemics, professional sport participation, and trauma to the lumbosacral spine. And that's all. Thank you very much.
So thank you very much for your presentation. It was a very good presentation. Again, my question, two questions. First is, I would like you to describe or tell us what was the conservative treatment. What do you mean by that?
The conservative treatment was going to the physiotherapists and implementing physical therapy.
And all of the patients underwent this?
Okay. Yes.
Do you know, was the length of the conservative treatment comparable between the patients, or?
Unfortunately, this data was often unachievable because of going to the, for instance, private physiotherapist and not having a proper in-hospital-like medical documentation.
Yes.
So it was hard to gather.
Okay, that's what I suppose. And the second question is, what was the reason of the necessity of the reoperation of these patients?
What was the necessity? As I said earlier, in the possible indications slide, the indications for surgery was the neurological deficits and pain, which did not subsided after the physical therapy and was continuous and was.
Yes, but my question was about the need of a reoperation.
Oh, reoperation. Oh,
so
sorry,
there's few cases that you showed about the patients.
Yes. I just misheard you. I'm sorry.
Okay, sure.
So the 3 reoperation cases. In one case, I believe after the 6 or 7 months, it was because of the return to the sports participation, and I am not aware of what happened to the one patient after 12 days. Okay. After the long time, it was the recurrence to the sports participation.
So there was only a recurrence to the sports, but you don't have the information. What was the reason of why the patient needed to be reoperated?
No, unfortunately, I do not have a particular information.
Thank you.
Thank you.
I have one more question. You have the data for over 10 years. I wonder how many of those patients came back for the second surgery after, I would say, some years? Have you analyzed that?
After some years, we are aware that no any more than these 3 patients came for the next reoperation. In the following,
were like in the first days or month. You don't have the data. What happened after a year or more? Or the operation, it doesn't mean the exact same level. Maybe the discopathy come back in some other levels.
When we were gathering the patient data, we checked for every main book number, and that was associated with a particular patient. So we checked every stay of the patients in our department, and no operations were then performed in any other levels of the spine.
Only those 3 they came back.
Yep, exactly.
I would like to ask you about the follow-up period. What kind of painkillers patient used during the follow-up treatment, and how long?
Unfortunately, I do not have information about how long, but firstly, they were usually treated with a doses of paracetamol or some anti-inflammatory drugs.
And how long don't you know now? Yes.
As I said, I do not unfortunately have information for how long period they were taking the painkillers.
Thank you very much.
Thank you.
I have one more question for you. Because it's very sad presentation, truly, because it's for young people and still you have to do surgery for lumbar discopathy, which is, of course, some kind of a social problem, truly. My question is, typically nowadays we're trying to avoid to do a surgery as much as possible. So we're trying to do some minimal invasive techniques. We use endoscopic surgery, etc. The main factor is to avoid entrance to the spinal canal, to avoid some adhesions later on, and the problems connected with those surgical issues. The question is, what do you think about the minimal invasive techniques for young children, because it's very young people there? And is it any possibility to use endoscopic procedures or any other minimal invasive treatment options for those people?
So my thoughts about this topic you asked about are the endoscopic technique should be also implemented because it is used with a big success rate in adults population, and I think that our department has not yet introduced the endoscopic treatment of lumbar discopathy, and I currently have no knowledge about the possible implementation of this technique, but I think that it should be implemented, but firstly tested about the possible and the future success rate of the procedures.
So you think about this endoscopic surgery might be an option for the people, for the young people there. And the second question about the follow-up time, there was from 9 or 7 days still to 5 days there. Typically for adult patients, it's 2 to 3 days. It is time for hospitalization, no more. For children, I think it's longer time. What's the reason for long hospitalization for those people, for those patients?
As far as I'm concerned, the children might have gotten an initial physical therapy in the hospital.
In the hospital?
Yes.
Okay.
And then they were put on a longer observation time.
Okay. Thank you.
Thank you very much.
Thank you for your presentation. And we go to the next. Następna prezentacja, która będzie przedstawiana, to będzie numer 8 na kartach do oceny. I tytuł prezentacji to jest Anterior versus Posterior Mechanical Thrombectomy, Characteristics of Patients and Comparison of Outcomes. Pan Michał Borończyk.
So, before I begin my presentation, I would like to quote Francis Crick, who was not only the co-author of the discovery of the molecular structure of DNA, but what a few people knew was also a neuroscientist. It is as follows: there is no scientific study more vital to man than the study of his own brain. Our entire view of the universe depends on it. In my opinion, these words are the quintessence of why neurology is such an interesting field of science. Dear Commission, dear audience, dear ladies and gentlemen, I would like to present you the result of our scientific work entitled Anterior versus Posterior Mechanical Thrombectomy, Characteristics of Patients and Comparison of Outcomes. To begin with, a few words about mechanical thrombectomy itself, which is currently the gold standard in the treatment of the acute phase of stroke. Mechanical thrombectomy is an endovascular treatment modality to physically remove thrombi from occluded blood vessels, such as brain arteries. The goal of mechanical thrombectomy is to rapidly restore blood flow and prevent tissue damage in patients with acute ischemic stroke. It should also be added here that recently the time window for mechanical thrombectomy was extended, which is currently 24 hours. Here I present you how the cerebral arteries are divided into anterior and the posterior circulation. The anterior arteries are internal carotid arteries, anterior cerebral arteries, and middle cerebral arteries, while the posterior circulation includes posterior cerebral arteries, basilar artery, and vertebral arteries. The vast majority of ischemic strokes occurs in the anterior circulation, especially in the MCA. Strokes in the posterior circulation are the minority, about 10 to 20%, depending on the source. In all these arteries presented here, mechanical thrombectomy is possible and is performed in case of their occlusion. Literature data comparing the efficacy and outcomes of mechanical thrombectomy performed in the anterior and posterior circulation are not always clear. Some studies suggest that there is a worse outcomes in the posterior interventions, while the other study indicates that the differences between these two groups compared are not statistically significant. In the meta-analysis cited here, authors proved that there is such a correlation, that is, posterior mechanical thrombectomy could be related with worse prognosis measured at 90th day of after stroke. However, this result was obtained only after a subgroup analysis, which included only the large samples. On the other hand, the reports about mortality are quite clear, with rates almost twice as high for the posterior circulation interventions. About the study itself, the aim of this study was to compare the characteristics, complications, and prognosis in patients who underwent MT in the anterior, AMT, and posterior, PMT circulation. We retrospectively searched and analyzed selected data from patients who suffered from ischemic stroke and were treated by mechanical thrombectomy. Data analysis was performed with appropriate tests and statistical models. On this slide, you can see a comparison of MT in the anterior and posterior circulation within some of the parameters studied. The total amount of subjects was 623, of which 57 were located in the posterior circulation, which was less than 10%. Statistically significant differences are age, median of which was lower in the PMT group, gender, that is, males more often underwent PMT, and NIHSS score, which was lower both on admission and after the procedure in the PMT group. In addition, I would like to point out that we did not find statistically significant differences neither in mortality nor in the patient's good prognosis, which was defined as at most 2 points at modified ranking scale at any of the time points searched. However, all these parameters are slightly higher in the PMT group. We divided the factors that influence on the patient's good functional status into those which effect was observed at discharge or at 90th day of stroke. At the first time point, the parameters which indicates a good prognosis were lower age, gender, lower NIHSS, lower time of procedure, and lower time from symptoms onset to intervention, whereas the presence of diabetes almost doubled the worsening of prognosis. At the 90th day of stroke, the positive factors were lower NIHSS, lower time of procedure, lower age, and presence of the atrial fibrillation and administration of Actylis during the treatment, while occurrence of the intracranial bleeding worsened the prognosis twice. I would particularly like to highlight that a relatively strong effect was made by the lower NIHSS in the both groups of patients and in the both time points. Here you can see the influence of selected phenodata on patient's functional status only in patients underwent anterior mechanical thrombectomy. The parameters that positively influenced both at discharge and at 90th day of stroke, it was a successful reperfusion treatment expressed in the TICI score as 2B or 3. And similar analysis, but for posterior mechanical thrombectomy, factors with the positive influence were lower NIHSS, successful reperfusion treatment, and lower time of procedure, while presence of leukocytosis and administration of Actylis worsened the outcomes. At 90th day of stroke, the positive factors were lower age, lower NIHSS, and lower time of procedure. Occurrence of leukocytosis, high CRP concentration, and performance of a burdensome chemicraniectomy worsened the outcomes. The following conclusions could be made from our study, which, in my opinion, the most important is the third one, that the neurological state of patients who underwent MT is the key prognostic parameter of the good functional state of patients in both groups. Thank you for your attention. I'll be delighted to answer any questions you may have.
Thank you for the presentation. In one of the previous talk, we've heard that there is a difference between the mother side and if the patients were sent from other sites. You presented the data from the single site. Do you have any information about your patients? They were sent from other sites to the mother hospital, or they were just sent to the mother hospital?
To be honest, we didn't check it at all patients, but when I'm thinking about it, the most patients are from the other hospitals, which were followed to the second stroke center.
In all of those patients, thrombolysis was the first line treatment?
If it was made, it was the first one.
You don't have data how many patients were treated first with thrombolysis and then went thrombectomy?
The statistic analysis we show here is the small amount of all our database that the answer to this question probably will be in our paperwork, but due to the small amount of time, I didn't reach all the data. I didn't remember how much it was. I'm sure it was higher than 50%.
One more question. The time window between the stroke itself and the treatment, because as you showed, the time frame is prolonged. Do you have those data?
Yes, we also have this data. To be honest, it was one of the purposes of why we performed this research, because literature data is completed about the comparison of anterior and posterior mechanical thrombectomy, but our database started in 2019, so at the year when the time window for mechanical thrombectomy was extended. So we, in the future, would like to compare our results with the results when the time window wasn't extended. As I say, we have this data, but we don't include it to this presentation yet.
I will look for your paper. Thank you.
Thank you so much.
Następna prezentacja to będzie prezentacja numer 9. Jest to prezentacja pod tytułem Risk Factor for Falls in Parkinson's Disease and Other Parkinsonisms.
Good morning, everyone, and welcome to my presentation. My name is Alexandra Buczek, and I would like to present to you risk factors for falls in Parkinson's disease and other Parkinsonisms. So let me provide you with a quick overview of the contents that I prepared for today. To begin with, I will introduce you to the topic. Then I will go through materials and methods that we used for the study. And finally, I will give you the results, conclusions, and engage in a discussion. Parkinsonism is a term that refers to a group of neurological disorders that share some common features with Parkinson's disease, including bradykinesia, resting tremor, rigidity, and postural instability. According to MDS-UPDRS, Parkinsonism can be diagnosed when bradykinesia and one other cardinal feature are present. So it has to be bradykinesia and resting tremor or rigidity or postural instability, but please note that postural instability is a late symptom. Falls are a common and dangerous complication of PD and other Parkinsonisms, often leading to injuries, hospitalization, and an overall decline in health and quality of life. Our study aims to explore those factors that increase the risk of falls in patients with Parkinson's disease and other Parkinsonisms, with a focus on identifying modifiable risk factors that can be actually targeted for intervention. Through a review of the existing literature, our study team encountered some recurrent findings, and notably, freezing of gait, disease duration, cognitive impairment, and medication use are one of the most prevalent fall risk factors. The study is a retrospective case-controlled study based on an anonymized database maintained by the Department of Neurology, Medical University of Silesia in Katowice. This database includes 735 patients diagnosed with Parkinson's disease or other Parkinsonisms, and the first group, so the study group, are 261 patients with a history of falls, and the second group, the control group, are 474 patients. Sorry, I'm a bit under the weather today. With negative falls history. So our group of patients mostly included patients with Parkinson's disease. Then there were patients with other types of Parkinsonisms like vascular Parkinsonism or drug-induced. And finally, patients with atypical Parkinsonisms. We decided to analyze those factors that appear to be the most significant across multiple studies. And these were age, sex, cognitive impairment, memory deficits, low vitamin B12 level, low blood pressure, dopamine agonist therapy, postural sway, arthrosis, polypharmacy, dyskinesia, disease duration, freezing of gait, walking assistance, and depression. So our study revealed that memory deficits, dementia, low vitamin B12 level, polypharmacy, requiring walking assistance, and postural sway are the most statistically significant and prevalent risk factors in patients with Parkinson's disease and other Parkinsonisms. And please note that 16% of patients who had experienced falls in the past had an injury afterwards. However, our study also revealed some contradictory data surrounding certain factors, like freezing of gait, depression, and dopamine agonist therapy. While some studies indicated these variables as notable risk factors, ours found them to be unrelated to fall risk in this population. So now, let me present to you the most relevant conclusions. Polypharmacy and low vitamin B12 level are the most statistically significant, potentially modifiable for risk factors in individuals with Parkinsonism. Memory deficits and dementia represent a serious issue for people suffering from PD and other Parkinsonisms. Individuals diagnosed with atypical Parkinsonian disorders are at the higher risk of falling compared to those with Parkinson's disease. So, when we have indicated the risk factors, what should be actually done to avoid them? Please remember to always measure the vitamin B12 level in your patients, and if the serum level is low, supplement it. Cognitive and memory training is massively important to suppress the process of dementia. Remember about regular medication review and adjust special mobility aids if your patients have walking difficulties. Implement regular medical checkups, and finally, encourage your patients to exercise regularly so it helps them to improve their balance. And I would like to regular medication review to be our take-home message today. Polypharmacy is an extremely common and a serious issue in today's medicine. Using multiple drugs simultaneously leads to adverse drug reactions, and most importantly for our study, it increases the risk of falls and cognitive impairment. So remember to always inquire about all the medications that the patient is taking to avoid using more drugs than necessary. Thank you for your attention, and if you have any questions, I am happy to answer them.
Thank you very much for your presentation. A wonderful work and a very big amount of patients you supplied here. So my question is two questions actually. Obviously, the first one is: did you include patients with the DBS stimulator implanted in your work?
No, we haven't had the data about the patients with DBS stimulation implants.
Okay. And the second question is: could you describe maybe somehow what is the how is it possible, or what is the pathway how the B12 vitamin in deficiency actually causes problems with the falling and gait with the patients?
Yes, so vitamin B12 helps the neurons, the nerves, to do their work properly, helps their functioning. So any deficits may lead to some neurological disorders and also to falls in Parkinson's disease and other Parkinsonisms.
So as we saw, your work was mostly about the analyzing these factors that affect it. But did you analyze, or maybe you're working currently on that actually supplementation of this vitamin B12 changes the way of this complication of falls, that how it looks? That do these patients improve actually with the supplementations of the vitamin?
No, we haven't analyzed it because it was a retrospective study, so we had only the database from the department. And yeah, this was basically the data that we worked on during the study.
Okay. Thank you very much.
Thank you.
Thank you for your presentation. Następna prezentacja, która będzie prezentowana, to jest numer 10 na kartach do oceny. Jest to prezentacja pod tytułem Selected Correlates of Positive Body Image in Sample with Multiple Sclerosis, a Preliminary Analysis.
Good morning, everyone. My name is Barbara Lewicka, and together with my colleague Kamila, we conducted a study about positive body image in patients with multiple sclerosis. This is the order of my presentation. First, I'm going to talk about the aims of the study, then I will present the materials and methods, the results, and after that, I'll conclude our work. Multiple sclerosis is a chronic neurodegenerative and progressive disease that can affect many areas of human body. But as healthcare providers, we usually focus on the somatic symptoms of the disease, but not always we think about the psychological impact of the disease. The first symptoms of multiple sclerosis usually appear between 20 and 40 years old, so in relatively young people. And when they start seeing the progressive disability, the changes in their body, they feel bad, and it can affect strongly their perception of their own body. And it has been proved that body image dissatisfaction can cause undesirable outcomes like depression, eating disorders, or even lower effectiveness of treatment and lower quality of life. The aim of our study was to assess selected correlates of positive body image in MS patients, like depression, anxiety and stress level, acceptance of illness, and personality traits. Into our study, we included 36 multiple sclerosis patients with the mean age of 40 years old. The study was held between January and April of this year. And in our study group, the mean time since diagnosis of MS was 10 years. For the study, we used surveys given in person and filled in place and under our supervision. And these surveys contained basic demographic questions, questions about the disease, and 4 psychological questionnaires that you can see on the slide. The first one was acceptance of illness scale, where the people had to assess how the illness affects their daily life and daily mood. The second one was depression, anxiety, and stress scale with 21 statements that patients had to assess between 0 and 3, how much they identify with them. The third one was the 10-item personality inventory, which assessed how the patients see themselves, if they see themselves extroverted or more reserved or more open. And so they were assessing these things between 1 and 7 points. And the last one that we focused the most on was the body appreciation scale, where patients had to assess statements like, I like my body, I feel good in my body, I feel pretty, between 1 and 5 points, which 1 was never, I never feel like this, and 10 was, I always feel like this. As I said, we focused the most on the body appreciation scale, and we checked which of the other factors were correlated with this score. For the analysis, we used the Pearson coefficient, and these are our findings. The positive body image was correlated significantly with a lower level of stress, anxiety, and depression in MS patients. People with positive body image had higher acceptance of illness and higher extraversion, emotional stability, and openness to experiences. There was no correlation between positive body image and agreeableness, and with consciousness, the correlation was weak. In conclusion, our study shows that the body image of multiple sclerosis patients is related to their emotional state, to acceptance of the disease and their personality traits. However, more studies are needed to assess how the examined correlates may act as protective or risk factors for the patients. And we would like to develop our study in the future. And currently we're looking for possibilities of collaboration with bigger clinics with multiple sclerosis patients to be able to develop the study and to make larger our group. These are more references, and thank you for your attention.
Your presentation. I have a few questions. First, those patients, all of them were relapsing remitting MS or different kinds of MS?
They were mostly relapsing remitting. I think we had 2 or 3 patients in the group with progressive, primary progressive one, but we decided not to differentiate the groups because of a small number of patients in total.
All of them were under disease-modified treatment?
We didn't collect the data about it, but they were all patients of a private clinic, and they were under supervision of a neurologist.
And one more question. Did you check at the gender differences? Because having the appearance of the body, definitely women are different than men.
Yes, we were thinking about it, but as I said, for the moment, our group is not big, so we decided not to differentiate the genders for the moment, because we had only 9 men in our group. So maybe in the future we will do this differentiation. But for the moment, we wanted to check the whole group together.
Maybe I missed this. What were the EDSS of those patients? Maybe they were shown, but I don't know.
We checked only the time since the diagnosis, but the EDSS, we don't have complete data about it, because it was a questionnaire that patients filled by themselves, so not all the patients knew their EDSS score.
What is your personal input to this study?
I was looking for some psychological tests to use in this study. I prepared the survey, and then I was going to the medical center to give the service to the patients. I was helping with filling the surveys. And also, together with my colleague, we prepared the database, and so we analyzed statistically the results. Thank you. Any more questions? Thank you very much.
Thank you for your presentation. Zapraszamy następnych prelegentów do zaprezentowania prezentacji pod tytułem Retrospective Analysis of to jest numer, już mówię, to jest numer 11 na kartach do oceny.
Good morning, jury and colleagues. Let me briefly introduce myself. My name is Zuzanna Olejarz, and I'm delighted to be here to present to you our work. Let me start with some general information. Brain abscess is an uncommon disease, but can cause long-term neurological deficits or even death. The prevalence of brain abscess is 1% to 2%, and the mortality rates ranged from 0% to 10% in the Western countries. Neurological symptoms and systemic signs are relatively non-specific. The aim of the study was to analyze clinical picture of patients and identify microorganisms associated with brain abscess. The medical records of 51 patients were analyzed. The patients were hospitalized from November 2001 to September 2022. The data was statistically analyzed. Our study group consists of 60% of male and 40% of female, aged between 26 to 73 years, with mean age 50 years. As you can see on the lower left graph, 2 times more patients were admitted in the first decade than in the second. All our patients were symptomatic, but only 10% of them had classic clinical triad of abscess. The most common symptoms were focal neurological deficits, altered level of consciousness, and headache. Let's skip to radiological findings. Computer tomography were performed in all our patients and MRI only in 40 of our patients. 10 patients had multiple abscess. I'd like to point out that the most common localization of single brain abscess were frontal lobe and temporal lobe. According to lower left graph, you can see that only 80% of a diagnosis based on computer tomography were brain abscess. Let's move to microbiological findings. 28 samples, it's 55%, were culture positive, mostly taken from blood, but 7 of them were taken from, mostly taken from pus, but 7 of them were taken from blood. And I'd like to also point out that a quarter of samples were polymicrobial. Let's move to distribution of bacteria. Gram-positive bacteria were predominant over gram-negative bacteria in all groups. Comparing 2 decades, it is decreasing distribution of gram-negative bacteria. And the most common isolated bacteria was Staphylococcus, Streptococcus, and Klebsiella in all group. But it is interesting fact that Streptococcus were predominant in the second decade. Let's skip to source of brain. The most common spread was cryptogenic, then post-operative, and the next contagious. Gram-positive bacteria also predominant according to dissemination, except of hematogenous spread and otitis. The most common predisposing factors of the brain abscess were past head surgery. Let's move to treatment. All our patient was treated with antibiotics, and 47 of them had operations. We divided the state of our patients according to Glasgow outcome scale. 5 patients died. However, 64% of patients had good short-term outcome. We analyzed factors which can affect outcome. Among symptoms on admission, only altered level of consciousness and meningeal signs increase the risk of mortality. To sum up, the incidence of abscess has decreased in the last decade, however, still remains the cause of persistent neurological symptoms or death. Computer tomography can be insufficient to establish a definitive diagnosis of brain abscess. And it is noticeable decreasing distribution of gram-negative bacteria and increasing distribution of Streptococcus species. The important factor of the survival is the state of patient on admission. That brings me to the end of my presentation. Thank you for your attention, and now I will open the floor to any question you may have.
Thank you very much for your presentation. A wonderful work as always. So my first question is about the follow-up of the patients. How did you perform the follow-up of the patients? What was the way that you gathered the data about the patients after being basically admitted maybe to a different hospital, or was a follow-up performed in our outpatient clinic, or could you describe it, please?
This part of our study is actually the short outcome. I think we should enlarge our work about long-term outcome of, as you said, inpatient clinic, and because I think the data. It's hard to find the data of patients which were treated, for example, in 2001 or 2022. So that's, I think we should try, but it's hard to find this history. And that's why right now we prepare short outcomes. So we prepare this like this when patients were finish this hospitalization. The mean age of the mean length of hospitalization was 30 days, plus minus 20 days. So after the treatment, we analyze the state of patients. So it's just a short short-term outcome. I think the conclusion can change when we analyze long-term outcome.
And my second and last question is about the methodology of treating the patients. Did you find the difference between the years that you analyzed of the way that these abscesses were treated? Whether was it a surgery or a conservative treatment? How were they treated? Did you find any difference between the years of the material that you analyzed?
Actually, according to operations, in last few years, trypanopunction is becoming more a common operation than craniotomy or craniectomy. In our study group, craniotomy was the most common, almost 40%. Craniectomy, I think, was 30%, and 7 patients had trypanopunction, which were performed in the last few years.
Thank you very much. This is a very important thing that you mentioned right now. Very interesting idea of how neurosurgery is changing its point of view a little bit through the years, and that it's pushing more forward into less invasive methods. But it requires a lot of analysis whether these methods are actually effective in the same way as they were in the previous times, where these operations were much larger. But for example, they allowed us to get much better view, for example, of the disease, or safer resection or treating of this kind of abscess. But this is just my comment on that. So thank you very much.
Thank you.
I have one more question. All those patients, the group that you gathered, come from neurosurgery department, right?
Yes, they were from the neurosurgery department. Some of patients were treated earlier in the other department, but came here to the operation to this our department in neurosurgery.
All of them, they were having single abscess, or there were multiple abscesses? It definitely changes the treatment.
Yes, 20%. It's 10% of our study had multiple brain abscess. So it was actually a small group of patients. But I think the interesting fact is that the patient with single brain abscess, we analyzed where the brain were localized. and the frontal lobe and the temporal lobe, they were the most common. I think it's the reason why otitis, sinusitis, or otitis, sinusitis, yes, that's the risk factors, and the most right now, I think, common the causes of brain abscess.
Thank you.
Thank you.
Thank you. Następna prezentacja to będzie prezentacja numer 12 pod tytułem Cognitive Impairment in Remitting Relapsing Multiple Sclerosis Possible Risk Factors.
Welcome everybody. My name is Paweł Dyczek, and today I'll be presenting to you the outcomes of the research that me and my colleagues conducted about cognitive impairment in remitting relapsing multiple sclerosis and its possible risk factors. Multiple sclerosis is an inflammatory neurodegenerative disease of central nervous system that affects mostly young adults. Next to its many clinical manifestations, one of its most prevalent symptoms is cognitive impairment, which can occur in 30 to even 70% of patients suffering from that disease. Since cognitive dysfunction is very detrimental to a patient's life, not only because of the effect on thinking processes, but also on, for example, social functioning, it's very important to detect this cognitive decline on its early stages of development. Therefore, the aim of this study is to determine the possible risk factors that can help us identify groups of patients that are more likely to develop cognitive impairment. So in our study, we have gathered 94 patients, adult patients with remitting relapsing multiple sclerosis. We have assessed their neuropsychological state using the above tests. And we also, in the search for possible risk factors, we have evaluated cardiovascular risk factors such as hypertension, diabetes, hypercholesterolemia, and smoking. We also gathered some other demographic data and disease characteristics. So in this table, we can see some overall characteristics of our group. We can see what kind of data we've collected, the disease characteristic, demographic data, for example, number of patients with cardiovascular risk factors. All right, so now as for the results. As it turned out, 69% of patients showed some kind of cognitive deficit, which is quite a large number. And in those 69% of patients, 22% of them showed severe cognitive deficit, which was defined as a poor result in all of 3 neuropsychological tests. Also, as we can see in the table below, the most commonly impaired neuropsychological test was ACE3. All right, so let's get to our main question. What are those possible risk factors? So in the first place, we have considered the EDSS score as a possible predictor. The EDSS is a scale that is used to assess the level of severity of the clinical manifestations of the disease. It's assessed in every patient with multiple sclerosis. The higher score in this scale, the worse the disability. And so, as we can see here, we have divided our patients into 2 subgroups. One of them with EDSS score equal or below 4, and other group with patients with EDSS score above 4. And we have assessed their neuropsychological state using SDMT test and ACE3. And as we can see on this chart, there was no significant difference in the outcomes of those tests between those two groups. All right, so maybe there is a predictive value of cardiovascular risk factors. Here again, we have divided our patients into two groups. One of the group without the aforementioned risk factors and other with those factors. And here we use the same tests, of course. And as we can see here, also there was no significant difference in the outcomes of those two tests. So how about educational level? And here we can see that as for the conclusions, only the educational level seemed to have some impact on the cognitive impairment. EDSS score or cardiovascular risk factor didn't appear to be a good predictor in this matter. And therefore, we believe that it's very important to assess neuropsychological state of every patient, even those at the early stages of the disease, because as our study showed, the cognitive impairment may appear on every stage of the disease. Thank you for your attention. If you have any questions, I will be glad to answer them.
Thank you for your presentation. Am I right that you noticed about 70% cognitive deficit among MS patients?
Yes, 69%.
And 22% severe?
Yes, 22% of those with deficits. So it was like 64 patients with some kind of deficit, and 22% of those patients had severe deficits. So there was like 14 patients with severe cognitive decline.
And could you repeat about EDSS score in this group?
Yes, of course. So on this chart, we can see that we have.
Can I ask about patient characteristic one before?
Yes, all right.
Yes, here.
So here the EDSS mean score was 2 points.
Can I see the mean EDSS was 2 points, yes, in all groups?
Yes, yes.
And what is range from which point to I mean the lower and higher EDSS score?
So the lowest was 1 point and the highest was 6, I believe.
These results are surprising because in this group, when we can see DSS2, it's a quite mild score of dysfunction, and I'm surprising about the results about 70% of cognitive deficits in this group. Thank you.
Thank you. Thank you very much.
Thank you for your presentation. Przechodzimy do prezentacji numer 13. Jest to prezentacja infratentorial brain tumors in infants, symptomatology and postoperative outcomes.
Good morning, ladies and gentlemen, dear jury. I'm Łukasz Dylewicz, and I'm honored to present you our research The topic of the presentation is infratentorial brain tumors in infants, symptomatology, and postoperative outcomes. So first, few words about the brain tumors in infants. They comprise about 8% of pediatric brain tumors with incidence of 1.1 per 100,000 live births. Unfortunately, they are often diagnosed when they reach big sizes. The infratentorial brain tumors in infants aged between 0 to 6 months comprise about 27% of the brain tumors, and in the group aged between 6 to 12 months, they comprise about 53% of brain tumors. The most common histopathological results are choroid plexus tumors, teratomas, astrocytomas, and embryonal brain tumors. Our aim of the study was to analyze the clinical manifestation and postoperative outcomes in infants with infratentorial brain tumors in Department of Pediatric Neurosurgery in Katowice. We conducted a retrospective analysis of medical documentation of infants being treated in our department between 2002 and 2022, and we analyzed the clinical manifestation, radiological and histopathological results, and postoperative outcomes. And now moving on to results. Our group consisted of 15 infants, 6 girls and 9 boys, with mean age of 8.9 months. All of the patients were symptomatic. ICP and focal deficits were seen among both 11 patients. The ICP deficits included vomiting and nausea in 73%, apathy in 60%, bulging fontanelle in 27%, and increased heart circumference in 20%. The most common neoplasm location was a fourth ventricle in 7 patients and in the brainstem in 5 patients. Histopathological results were, we observed a big variety of them. However, 12 of the brain tumors presented high malignancy, and only 3 of them, presented low malignancy. The most common surgical approach was a suboccipital craniotomy with cervical laminectomy in 86.6%. Other approaches included temporal and retrosigmoid craniotomy. The gross total resection of the brain tumor was achieved in 5 patients. The subtotal resection was performed in 2 patients. The partial resection in 6 patients, and in 1 patient, only biopsy was performed. The improvement in functional status of the patient was seen in 10 cases. Complications were reported in 5 patients, and they included respiratory failure, acute internal hydrocephalus, and subcutaneous fluid collection, and bronchitis. The operations were performed in 7 patients. In 5 cases, the ventriculoperitoneal shunt implantation was performed. Additionally, 2 cases included the partial removal of tumor recurrence, and the final improvement in functional status was observed only in 3 patients. And now, coming to conclusions, infratentorial brain tumors are very rare neoplasm among infants, and they are characterized by high malignancy and poor outcomes. Non-specific symptoms lead to delay in diagnosis, and surgical treatment is a preferable treatment technique, but it often leads to serious complications, and the gross total resection is unfortunately rarely achieved. Thank you so much.
Thank you for your presentation. The questions from me, just a few questions. First of all, I would like to ask you about the reasons of the reoperations. Obviously, what were the reasons of the reoperations of those patients?
In most of the cases, it was unfortunately surgeons were not able to achieve a gross total resection, so the brain tumor was there, and some of the patients had a brain tumor recurrence. So that was the.
Do you know if they underwent any other therapy that, or was it only just a neurosurgical therapy, or there was a radiation therapy?
Actually, all of the high malignancy tumors in patients were treated with chemo and radiotherapy. Unfortunately, a lot of them were treated, they were transferred to other departments. So there is no data of the results.
And you mentioned a few cases of the collection of the subcutaneous fluid after the surgery of the posterior fossa surgery. You know if those cases required a reoperation, or were they treated conservatively and didn't require reoperation?
I believe that one or two cases, one or two patients needed the reoperation because of that.
Okay. And my last, it's not a question or more like a comment. There is one big problem about a lot of works and scientific papers of neurosurgery, which consists analysis of the tumors from the years between 2000 and 2022. Because the WHO classification of the tumors, which is our most important reference paper of what we base our histological analysis of the tumors, changed very, very much. And based on the recent papers of the 2020 or 21, I think we are now not allowed to actually call any kind of anaplastic astrocytoma, for example, an anaplastic tumor. There is no such a name for this tumor no more. Now we consider the most important factor a genetical analysis of the tumor cells. There are some things that are analyzed, and it's not important right now, but it's not something that I say against this work, because this is what happens in every scientific paper from neurosurgery right now. The histological analysis is actually not up to date. And this is a big problem, because sometimes you cannot analyze what is the difference between the outcomes, for example, based on the histological result of this tumor. But thank you very much for answering questions.
Thank you for pointing it out. Are there any other questions?
One question about the procedure right here. Because I understand here the plan for surgery is just a resection, okay? The gross total resection, and then do you follow up the patients? Afterwards, you have 5 patients with post-op shunt procedure. So I mean that there are some hydrocephalus, and then you're using shunting procedure. So my question is, so the plan for each surgery that you reach GTR during the surgery, and you don't need any more for shunt for the future for those patients, isn't it? This is, as I'm wrong, all right. So you don't plan a shunt procedure at all, just on the beginning. It's a complication procedure for you later. Because if you plan a surgery for huge tumor in posterior fossa, it means it's very difficult surgery, typical for young children, 9-month-old children, for small children. It's typically difficult. And you said in conclusion that this is very, very rare that you reach GTR during the surgery. So you can at least on the beginning, you can think that it might be impossible to reach the resection, full resection, and the hydrocephalus will be connected with the post-op situation. So you don't plan a shunting procedure or external drainage before the surgery to get the better results of the surgical procedure?
I think that main goal is to have a gross total resection, but like you said, the main goal is to actually have the best result that we can have. So maybe the performing that shunt is in some cases is just important. So
yeah, no, we know that shunt is not a good idea, and we know that the best shunt is no shunt. This is the statement for neurosurgery. It's the typical statement. We avoid shunting procedures. But at this point, do you use external drainage during the surgery and post-op situation, or you don't use external drainage during post-operating time after surgery, regular one?
I think this is the better question for the neurosurgeon, actually.
Okay. No, that's what I'm questioning, because the typical complication and all of this was shunting procedure, like was the planned complication almost in these cases. But well, most interesting. Thank you very much.
Thank you. Thank you for your presentation. I przechodzimy do ostatniej prezentacji dzisiaj, która będzie przedstawiona. Jest to prezentacja numer 14 na kartach do oceny pod tytułem The Assessment of the Concentration of Pentraxin-3, Osteocalcin and Osteopontin in CSF in patients with multiple sclerosis.
Good morning and hello, dear jury and colleagues. Today I want to share with you some results of my survey, of the survey of my department. And the title of my presentation is The Assessment of the Concentration of Pentraxin-3, Osteocalcin and Osteopontin in the Cerebrospinal Fluid in patients with multiple sclerosis. Now let me tell you something more about the essence, about the definition of multiple sclerosis. This is a chronic disease of the nervous system which belongs to the group of demyelinating diseases. The sense of this disorder is multifocal, disseminated, we can say, degeneration of brain and spinal cord, which consists of vanishing the myelin sheaths in nerve fibers. And what is important that women suffer from multiple sclerosis more frequent than men in the ratio of 2:1. Now I want to say something more about the immunosenescence phenomenon. And this is a process which includes changes in the immune system relating to the aging. And the features of this process are as follows. The delayed response of the immune system, for example, for infections, a tendency of the organism, of all the organism to the inflammation, and an increased risk of autoimmune diseases occurring. And in patients with multiple sclerosis, comorbidities were established more frequently than it was suspected. Now, biomarkers. Pentraxin-3 is acute phase protein being thought as a marker of local inflammation. Osteopontin is a pro-inflammatory cytokine which is relevant in the pathogenesis of the autoimmune diseases. And osteocalcin is a non-collagenous protein secreted by osteoblasts, which plays a role in bones mineralization. And what is interesting that it is a highly specific marker of a bone turn, and it testified to the osteoblast's activity. Now let me tell you something more about the materials and methods which we used during this survey. The aim of a study was evaluation of the concentration of PTX3, OPN, and OCN in cerebrospinal fluid in patients with MS. 52 patients treated in the Department of Neurology in Zabrze were enrolled to the study. And the multiple sclerosis was diagnosed according to the McDonald's criteria from 2017. The CSF and a blood serum was taken from each person. Now please have a look at this chart. And as you can see, the vast majority, because 79% of the entire group belongs to the relapsing remitting multiple sclerosis. Now have a look, please, at this chart and the table. And according to the points obtained by our patients in EDSS scale, here the highest score, because 4.5 points, is in a group of primary progressive multiple sclerosis. And this is the median value. A range in this case is 4 to 5 points. Now, what about the age of patients enrolled in the study? The oldest group belong to the patients with PPMS, and a median value is 48 years. And as you can see, the youngest group, here the median value is 36 years, and they belong to the group of relapsing remitting multiple sclerosis. Now let's speak more about the duration of MS. And the longest duration is in a group of secondary progressive multiple sclerosis, because here median value is 9 years, and it includes to the range of 1 to 20 years. Now, a percentage participation of patients without any treatment and patients without immune modifying treatment in the entire group belongs to the 86.54%. And here the highest, the numerous amount of patients are in the group of PPMS, because it's 100%. Now the relapse has been diagnosed in a group of 24% patients. The frequency of comorbidities occurring in the study group. As you can see, in the entire group, all of those disorders are more common, because dyslipidemia includes the range of patients in 63%, hypertension is 19%, and thyroid disorders, it is fluctuating in 12%. And these scores are definitely more common than in common population. Results of our survey. The concentration of osteocalcin has been significantly higher in the cerebrospinal fluid in patients with SPMS than with RRMS. The concentration of pentraxin 3 has been significantly higher in CSF in patients with multiple sclerosis who are established increased level of IgG in CSF. The concentration of osteopontin, the second of our biomarkers, has been significantly higher in patients who are established a presence of oligoclonal bands in CSF. The significant positive correlation of osteocalcin concentration and EDSS scale has been established. The significant positive correlation of the LDL cholesterol concentration and points gained by patients in the EDSS scale has been established. The significant positive correlation of the triglycerides concentration and points obtained in the EDSS scale also has been confirmed. And now let's have a look at the conclusions. Pentraxin 3, osteopontin, and osteocalcin, despite their previous use in the diagnostic of another disorders, may become useful biomarkers in MS. For example, obtaining a result of increased osteocalcin concentration in patients diagnosed as PMS suggests that these parameters matter in a diagnostic of possibility of recognizing this form of MS. And significant correlation between LDL triglycerides and level of disability in patients with MS has been confirmed. And I think these biomarkers can be considered as useful biomarkers in differentiation of MS types and in evaluation of the activity of this disease. Now, thank you so much for your attention, and I'm looking forward for some questions.
Congratulations on your work. I have a few questions. Majority of your patients were not treated yet, right? So it was like during the baseline analysis, right?
Yes, that's right. The main way of our study was diagnostic and not treatment. We didn't concentrate on that, but I hope and I think that our analysis, our study is the basis for further studies, for further analysis.
So lumbar puncture is an invasive procedure, so it's always difficult to ask the patients to agree for such a procedure. But well, right. In the MS is different story, right? Because in majority of those patients, we still perform the CSF. You showed the majority of your patients were lapsing remitting MS.
Yeah.
And in the other patients with the secondary progressive and primary progressive, you perform lumbar puncture as also the routine procedure or just for the purpose of this study?
They were a purpose of the study, but yes, the patients with secondary progressive multiple sclerosis and primary progressive multiple sclerosis were also enrolled in this study. But we concentrate on this group of patients because they were a vast majority.
Definitely data-driven by the RMS. Okay, and you showed the slide with comorbidities.
Yeah.
Actually, you showed only 3 comorbidities. Does it mean that there were no other comorbidities, or only those 3 that you showed are important on somehow? Then what is the importance of those 3?
Yes, thank you for this question. Well, that's right that these patients and also another patients with MS suffer from another also comorbidities, but these dyslipidemia, hypertension, and thyroid disorders were the most numerous amount of comorbidities, and we think that it's also an interesting field for another survey in the future.
Dyslipidemia is very common in the society, so maybe
yes,
this is just...
Yes, and here it's really frequent.
But does it mean in your questionnaire, you asked in general, do you have any comorbidities for a patient, or you just listed them and the patient like were ticking?
We have a list of comorbidities.
Other were not important for you?
Yeah, in this study definitely, and we think in the further studies in the future also they are not as important as these disorders.
Majority of your patients were relatively young, which is obvious for the multiple sclerosis patients. Can you go a bit further into this senescence of the immune system? Definitely doesn't mean the age of a patient, right?
Yes, it doesn't mean the age of the patients because as we considered and as we noticed during this study, that immunosenescence and, for example, some delayed responses of the immune system and a tendency for another autoimmune diseases are quite common, and even in the group of younger patients, for example, at the age of 36 years.
That's why I asked about the comorbidities, because it's a bit surprising that only thyroid dysfunction was listed here. But yes. Thank you very much. Thank you.
Thank you also. Are there any other questions from the audience, for example? No. Okay, so thank you so much for your attention.
W takim razie przeszliśmy już do końca naszej sesji. Wszystkie prezentacje zostały przedstawione przez uczestników. Także dziękujemy bardzo za uwagę i jeszcze prosimy panią profesor o kilka słów na koniec, które podsumują to, co usłyszeliśmy tutaj.
Dziękuję bardzo. Szanowni Państwo, ja chciałabym bardzo serdecznie przede wszystkim pogratulować wszystkim dzisiaj prezentującym młodym naszym kolegom. Oczywiście również osobom, które były odpowiedzialne za nadzór i merytoryczny, i nadzór techniczny. Ja jestem pod ogromnym wrażeniem, muszę przyznać, że jestem pod ogromnym wrażeniem. Prace miały naprawdę bardzo szeroki zakres, jeżeli chodzi o metodologię. Usłyszeliśmy prace, które dotyczyły badań ankietowych, badań laboratoryjnych, badań analizujących, prezentujących serię przypadków, także naprawdę bardzo szeroki przekrój. Przy tym pięknie przygotowane prezentacje. Tutaj myślę, że wszyscy jesteśmy zgodni, że te prezentacje naprawdę były na najwyższym poziomie. Jestem pod wrażeniem też biegłości języka angielskiego i świetnej dyskusji. Praktycznie wszystkie osoby, które brały udział w dyskusji, nasi młodsi koledzy, prowadzili dyskusję w sposób niezwykle profesjonalny. Faktycznie byli bardzo dobrze w danym temacie zorientowani i czasami nawet dygresje sięgały innych tematów niż dotyczyły ich prezentacje. Także ja jestem pod ogromnym wrażeniem. Bardzo serdecznie wszystkim Państwu gratuluję. Oczywiście musimy wziąć pod uwagę tutaj zawsze wkład własny. Myślę, że z punktu widzenia oceny prac Państwa studentów bardzo istotnym pytaniem, które zresztą słyszeliśmy wszyscy, pojawiało się wielokrotnie jako pytanie od członków komisji na temat wkładu, bo widzimy, że no trudno, żeby wkład danego studenta mógł być taki sam przy prezentowanych operacyjnych przypadkach, jak przy powiedzmy badaniach ankietowych. Natomiast jakby w żaden sposób nie umniejsza tutaj ta wiadomo rola charakteru tej pracy, ponieważ to, co Państwo dzisiaj prezentujecie, to prezentujecie pewne wyniki, które są efektem Państwa dojrzałości naukowej. I tutaj z tego miejsca bardzo serdecznie Państwu dziękuję i gratuluję. To naprawdę przyczynek do dalszego rozwoju naukowego i my troszkę starsi od Państwa koledzy będziemy na pewno tutaj Państwa wszystkich wspierać, ażeby ta droga naukowa była dla Państwa otwarta. Myślę, że chyba z mojej strony wszystko. Ja też serdecznie gratuluję Państwu prowadzącym dzisiejsze spotkanie, bo faktycznie nosi to znamiona takiej w pełni profesjonalnej, na pewno nie studenckiej, a w pełni profesjonalnej konferencji naukowo-szkoleniowej. Także jeszcze raz serdecznie gratuluję wszystkim i pozdrawiam.
Dziękujemy bardzo za te słowa podsumowania. I pragniemy podziękować wszystkim członkom komisji, czyli właśnie pani profesor Monice Adamczyk-Sowie, pani doktor habilitowanej nauk medycznych Joannie Siudzie, pani doktor nauk medycznych Elżbiecie Zych-Twardowskiej i panu doktorowi Mikołajowi Dymkowi za to, że prowadziliście Państwo bardzo ciekawą dyskusję. Myślę, że ona bardzo dużo wniosła tutaj. Oraz za ocenianie prac, które wygłaszali nasi prelegenci, no i za obecność, bo dzięki Państwu się ta sesja mogła odbyć. Również wszystkim uczestnikom, że zgłosiliście się, że zrobiliście te prace i że je przyjechaliście tutaj wygłosić. Także jeszcze raz w imieniu całego STN-u dziękujemy.
Jeszcze, jeżeli Pan pozwoli, ja też chciałam kilka słów od tej części komisji, która jest na żywo tutaj. Bardzo dziękuję, też jestem pod wrażeniem merytoryki przygotowanych przez Państwa prac i tego, że mamy po raz pierwszy chyba, tyle ile ja jestem w komisjach, taką równowagę między neurologią i neurochirurgią, tak, bo sesja zawsze ma te dwie dziedziny w sobie łączy i dzisiaj wyjątkowo mieliśmy możliwość wysłuchania no, bardzo dobrych również neurochirurgicznych prac, nie umniejszając pracy neurologom. I jedyne, jeżeli mogę takiego wrzucić łyżkę dziegciu do tych wszystkich bardzo pozytywnych podsumowań, Państwo, którzy jesteście na widowni, też zadawajcie pytania, prawda, bo to też właśnie daje kolegom możliwość wypowiedzenia się i też pokazuje Wasze zainteresowanie tematem. Ja zdaję sobie sprawę, że pewnie każdy był przestraszony czekając na możliwość wystąpienia swojego, ale myślę, że to też podnosi, tak jak mówiła Pani profesor, tą jakość Państwa wystąpień, Państwa i Państwa kolegów, więc bardzo proszę, byście następnym razem również wzięli to pod uwagę, ale tak, bardzo dziękuję jeszcze raz wszystkim, którzy przygotowali i bardzo dziękuję organizatorom i za zaproszenie i za to, że wszystko przebiegło w miarę sprawnie. Bardzo dziękuję.
I jeszcze na sam koniec chciałem zaprosić wszystkich, ponieważ jest w piątek zakończenie o godzinie 16:15, więc wszystkich uczestników serdecznie zapraszamy i jeszcze zapraszamy na warsztaty, które się odbywają w holu głównym. To są warsztaty kosmetyczne. Przekażę głos może koleżance.
Dziękuję bardzo. Tak, w bardzo telegraficznym skrócie. Warsztaty z szycia chirurgicznego odbywają się od 11 do 13 w sali 117. Warsztaty z wirtualnej kliniki w sali 108 od 10 do 13:30. Warsztaty z kuchni molekularnej w sali 220 od 11 do 15. Warsztaty z laparoskopii w sali numer 108 od 13 do 15:30. Naszych fizjoterapeutów możecie spotkać w Centrum Symulacji od godziny 11 do 15, a w budynku głównym obok punktu z kawą czekają na Was członkowie Studenckiego Towarzystwa Diagnostów Laboratoryjnych, którzy bardzo chętnie sprawdzą, ile bakterii znajduje się na Waszych telefonach, oraz doktorantki, które wykonają Wam takie parafinowe maski na dłonie.
Tak, także dziękujemy. Jeśli ktoś jest zainteresowany, to wszelkie informacje są dostępne na naszej stronie internetowej. Można też podchodzić do rejestracji i tam się pytać, bo też udzielają wszelkich potrzebnych informacji. I o godzinie 13 przyjeżdża catering, także każdy z uczestników ma zagwarantowany posiłek. Jest w dwóch wersjach, mięsnej i bezmięsnej. Także tym miłym akcentem kończymy, kulinarnym. Dziękuję bardzo.